first of all, Dr. Duarte, thank you so much. I know the time was very constricted and you still managed it, and I am so thankful for this. And I hope we do lots of webinars together. But to start with, the stage is yours. You can start.
Okay, fantastic. First of all, thank you, Kurasan, for this invitation, and thank you, Shnia, for this your persistence in we doing this webinar in this format that we hope to do it more and more often in the future, and to share clinical cases and clinical experience. Today, our seminar will be about 𝗬𝗪 bioactive. We will try to be dynamic with some concepts that we would like to stress and reinforce. And of course, the best of the seminar is the clinical cases that we will present in this webinar also. This bioactive is important to know that we are talking about pure phase beta triphosphate calcium technology with silicate that is a boost that is improving the quality of the biomaterial for biomechanical stability and also with high porosity. We are talking about a material with more than 75% of porosity that gives more 10% of porosity when we compare to other materials in the market. And this is very important because in this space we can have blood, we can have fibrin, we can have more adhesion between our biomaterial and the autologous bone. Of course, that we know that the human bone has a porosity around 80%, what means that the 𝗬𝗪 bioactive is very similar to the human bone in terms of porosity. In contact with the vital bone, this material is resorbed by the body over a period of months and simultaneously replaced by local endogenous bone. Is why it's so important the macrovascularity around our biomaterial and avoid the contamination with saliva of our biomaterial, which means that we should close very well our wounds with stitches after the surgery. As this synthetic bioactive ceramic material has excellent intra and extra-osseous tissue compatibility and no toxicity, nor locally or systemic. This is very important because nowadays the patients are very concerned about toxicity of the biomaterials that they put in their bodies. And for us as clinicians, we want to be the most in a better position in terms of safety for ourselves and for the patients, of course. Unlike materials of biological origin, does not pose any risks of infection and sensitization. That is very, very important also. The safety of our procedures must start by ourselves, our teams, and all the materials that we use. And the presentation that we use more is in granulars. This is a very, very clean package that is very easy to identify in our clinic, in our surgical theaters, is nice to handle. In terms of indications, where we use the 𝗬𝗪 bioactive, the defects after bone cysts removal, as I done today, that we are talking before this webinar, is very useful because now we have two concerns, not only to remove the totality of the cyst, that is very important, but also to prepare the bone for future rehabilitation, for instance, with implants. And in the same surgical time, we can remove the cyst and do the bone reconstruction. The augmentation of the trophic alveolar ridge. Sometimes we have patients that they didn't done the reconstruction when they extract the teeth, and after several years they decide to place implants. But when we evaluate the bone availability, we know that it's not enough bone to place implants in the 3D position, what means that we should do the bone reconstruction because the maxilla or the mandible are very trophic. The sinus floor augmentation is the most widely done surgery in terms of oral surgery, because we know that the posterior teeth are the first teeth that the patients will lose. And of course, there is a bone atrophy, and we need to regenerate that anatomic area before we place the implants. Filling alveolar defects after tooth extraction to maintain the alveolar ridge is very, very important, mainly in aesthetic areas. When we are talking about anterior maxilla and anterior mandible. And this is very important, this kind of a surgical approach. And filling of two or even multiple wallet intrabony pockets, and even in biotrifurcation defects, molars, because we know that it's very important to clean the granulation tissue that is in the pocket, and at the same time to do the reconstruction. Retained teeth or corrective osteotomies is also another indication, and we are talking about not only wisdom teeth, but for instance canines or even premolars in strategic areas that we need to reconstruct for future orthodontic movements or also for implant placement. And we know that general defects are also very, very important to correct. Let's go for the first clinical case. This is a very challenging clinical case, and we used the 𝗪𝗀𝗄 bioactive. It was not only for us a challenge, but also to test the biomaterial and do clinical research. We should use the products in this kind of cases, not only the easy cases, but also the difficult cases, because from there we know, because we have a right perspective about the quality and the outcome of each biomaterial. And this is a very young patient, and we are talking about 28 years old, female, Caucasian, no alcohol, no smoking habits. She has a carcinoma in the first quadrant. She was reconstructed. That was done the removal of the carcinoma, and in the same surgical time, it was a fibular bone reconstruction. The bone was exposed, the soft tissue was exposed, and when we received the patient, like 2 years after the first surgery, we had a very challenging situation. As you can see here, we are talking about 4 teeth, the lateral, the canine, the first premolar, and the second premolar in a very young patient. And when we look to the CBCT in the image, you will see that is a lack of bone, a massive lack of bone, not only in width, but also in height. It was a 3D defect, and the challenging was complete. The first step was to put down the patient's expectations, and we told her that we shouldn't be possible to do the bone reconstruction in one step. We will have 2 steps to do this. The remaining autogenous bone was very few, and we decided to do the first surgery to reconstruct the most that we can to create a bone basis, and in the second surgical time we will place implants and we will do a second bone augmentation. And this is the first idea, first images, as you can see there. And the 3D, we will see the defect, which was massive. We still have a osteosynthesis plate that we keep there to give volume or to attach a membrane during the surgery. We didn't remove because it was also an orientation point for us. When we treat this kind of patients and with this age, we are not treating only the patient, we are treating the family, and the expectations are very high and the demand is also very high. Now,
For this, like the defect seems to be larger. Can you please let us know how much, like approx defect it was?
oh, we are talking about maybe, I think, maybe more than almost 3 centimeters,
Okay.
30 millimeters, and in high, we are talking about 15 millimeters. It
Okay.
was a massive defect. And the worst scenario comes after these radiological images, because we not only have the bone defect, but also the soft tissue, as you can see here, is completely stretched, and there was no keratinized mucosa already. Um, and the patient in her mind, of course, she wants naturality. She wants that we reconstruct the maximum that we can. But in these kind of clinical situations, we have the bone and also the soft tissue to cover all this. And we need to think in all the items, because the final result will be part of all these items. And the first idea, as you can see there, was to say to the patient, okay, we need, no matter how many surgeries we will have to do, but we need to protect the bone defect, the bone grafts that we will do. And the first idea was to use some autologous bone from the chin, that we cut it with the piezo surgery device. We tried to do a micrometric cut with cavitation effect, and we use this autogenous bone to give some consistency. We close it and we open in the defect. And as you can see here, we were not aware about all the characteristics of the bioactive, and we decided to mix the bioactive with autologous bone to see their behavior. And we using the bioactive, and using also fibrin from the patient, we done the sticky bone. And normally, I like to put the membrane and to put some metallic screws to give some stability to the membrane before I place the biomaterial. And another very interesting point with is with the piezo device, we do some um, marks in the autogenous bone, trying to create some microvascularity. This microvascularity will be very important for the attachment between our bone graft and our autologous bone. With the tip of the piezo surgery device, we create these walls, small walls, to create to get more vascularity. As you can see here, we place a huge quantity of bioactive with autologous bone. And the first idea was to create this base, this bone base. The screws and the membrane. And in the top of this is osgide membrane. This is a resolvable membrane from Curzan that I like a lot, because it's a large membrane, it's very malleable. We can adapt to the bone defects, and we can adapt to the alveolar bone also. And on top of that, we place also some fibrin membranes to give an extra coverage to this bone defect and to this bone graft. Of course, we know that our flap will be difficult to close. Normally, we use two kinds of stitches to have the maximum closing of the soft tissue. And we use a glue, a periacrylic glue, on top of our wood to reinforce the soft tissue attachment. Of course, that the patient is advised to have a calm life during the first days, not work if possible, not place a removal prosthesis, because we know that is important, the contact of the wood with the air, the cicatrization is very, very important, and the first hours are a major concern. We will see our bone defect here in detail, and what was our result. Of course, it was a nice result, but not enough result. And when we see the OPG is always a good starting point, but it's not the 3D volumetric exam by excellence. We always love the CBCT. CBCT gives us the full scenario. And as you can see here, we start to build a bridge, a bone bridge with our bone graft. And it was very important because it seems that we can create good bone substrate. And the major advantage from bioactive, the density of the biomaterial, very, very important. That was completely, we could see from the beginning, that was a lot of granules, the compact granules, they were very important, and the adhesion between the biomaterial and the autologous bone. Of course, in this case, we have also the bone graft from the bone from the chin that give us here a mixed 60-40 mixed of the constitution of our graft. But it was nice to see there was no spaces, there was no reactions of the patient. And cut by cut, we analyze how our bone was kept, and we noticed that this silica gives more volume to the bone graft, and of course we need the patient collaboration. And in the 3D, and we will see in a few slides how was the evolution of the patient, but here we can see how the bone graft was consolidating. And after 15 days, this is the aspect of the patient. We place a compressive plate on is an adaptation of the removable prosthesis with a strong basis in the palate, and trying to avoid occlusal strong forces in our bone graft. And after 6 months, we decide to reopen our bone graft and place the implants. This first surgery allow us to place 4 implants with primer stability. And I'm talking about 40 Newton per centimeter in terms of primer stability, what is very, very good in regenerated bone. We place 4 implants, as you can see there, and the implants in the lateral incisor and second premolar, they were almost complete in bone from the first surgery. The canine and the first premolar, they have a lot of threads exposed, and we were counting with that. The patient was completely aware of that, and our goal was to do a second bone reconstruction already with the implants placed. Again, we use the os-guide membrane now by palatine, as you can see there. We managed to do a full thickness flap, not only for the vestibular detachment, but also for the palatine detachment. This allows us to put the membrane and stick the membrane in a very, very secure way. And as you can see there, we fulfill our bone defect, the threads that they were exposed, now only with bioactive. Ceresorb bioactive was our only biomaterial to this second step of the surgery. We managed to put some fibrin glue, natural fibrin, with extract from the blood of the patient. And as you can see there, the porosity is making already is changing, because As soon as we place the biomaterial in contact with bone is amazing, because you see by the color, the white changing for red. It seems like the porosity absorbs all the blood that is in the area. On top of these bioactive granules, we place also fibrin membranes again, and giving a contour of the new maxilla. We stitch very well, and here you can see already our implants. And it's important to again to go to the CBCT. And when we go to the CBCT and we go cut by cut, we will see that now we are placing not only the implants in the first bone graft that we done, but also in the second bone graft that we done. And the implants are completely in bone. Of course, we try to maximize the bone as far as we can. And here is the initial situation. We start by this 3D. This is our original bone defect. After the first surgery, we managed to get maybe 1/3 of our bone reconstruction. And in the second intervention, as you can see here, and already with the implants placement, we managed to do the 2/3 of our bone reconstruction. In the first surgery, the bone graft was done by autologous bone from the chin and also 𝗪𝗀 bioactive. And in the second surgery, we only do the bioactive to consolidate the bone. And this is our first paper from this clinical case. It was only the case report with preliminary results. We were very enthusiastic, and we published in the Implant, the International Magazine of Oral Implantology in 2023. And now we hope to publish the second paper already with all the clinical case done, and of course, and the third paper with the oral rehabilitation and the follow-up of our case. And this is a very challenging case that help us to test the biomaterial and to see all the characteristics and how the biomaterial works well. A second case, also a very difficult one, a case of one patient that is not living, is living abroad, is a young patient with 45 years old, already with the removable prosthesis for several years. And he came to us for a first opinion about implants rehabilitation. Now, this is a typical atrophic maxilla, no bone in the posterior area of the maxilla, some bone in around the teeth that the patient has, like the canine, and also a lack of bone in the anterior premaxilla. As you can see there, the patient was using a removable prosthesis for a long time already, and now his economical situation allows him to place implants. And we have here the bone around the canines, but the problem was that the bone was very, very thin. Here it is. It's a completed lamina of bone. There was no enough bone to place implants, and it was a very challenging situation. And here it is, the resorption of the premaxilla with this wave, this concavity that is very typical of the premaxilla. The canines hopefully keep the bone between them, around them, but the posterior area of the maxilla and the premaxilla was not bone at all. What we decided to do, okay, we saw the mandible, and the mandible has a premolar, impacted premolar lost there. The patient doesn't want to touch on this, just for us to anatomically to know. But the mental area, there was some prominent bone that we could combine with our bone reconstruction, and was what we decided to do. We decided to go to the autologous bone of the mental area, because this osteogenesis characteristic is very important for us. We detach all the mucosa in the premaxilla, and we fixed our bone graft from the chin. Of course, that we always try to have microvascularity. I'm very, very aware of this situation. Creating a link between the new and the old bone is very, very important. And of course, with these two blocks of bone, uh, we cannot say that we have anterior bone reconstruction. We need more than that because there is no continuity on these blocks, just two blocks. Okay, for that and for the continuity of the premaxilla, we decide to reconstruct all the space with a 𝗪𝗪𝗏 bioactive combined, as you can see there, with autogenous from the metal area. We cover all the graft with the 𝗬𝗏 membrane. We close very well this area. Here is the image, intrasurgical image. And after 4 months, this is the situation in terms of not only soft tissue, but also bone volume, we change completely. Of course, we done some restorations on the canines just to keep them healthy for a while. Not only the tooth was important, but also the soft tissue. We are always very concerned about the soft tissue. The patient use removable prosthesis during the healing period, and we decide to place 2 implants in the same surgical time. We done the bone graft and we put 2 zygomatic implants in the posterior area. Zygomatic implant, they have anchorage in the middle face, in the zygoma bone, what gives the posterior stability, the strong stability to our oral rehabilitations. And in the second stage, we decide to place more 2 implants in the anterior area, exactly in the area that we done our bone graft. My cases, because are so severe cases, I do it sometimes step by step. I build the case during the time. And here it is, the CBCT of our bone reconstruction, as you can see there. We always have this plan in our mind, not only solve the case for now, but give some planification for the future, is what we always try to do. Not only place 2 implants in the anterior area now, but also to do the bone graft, and in the next future, in this case, 6 months after, we place more 2 implants in the anterior area. The patient was too young for not having this kind of planification. And here we have the anterior implants and the posterior implants. As I told you, zygoma bone and premaxilla, as you can see there. And the final result, not yet. For now, just more 2 extra implants placed in our bone graft site. Okay, with these 2 cases, I can show you what we test with the 𝗪𝗪𝗏 bioactive. And the final slides are trying to tell you about limitations and advantages of this biomaterial that we find. Of course, acute and chronic surgical infections are not only for the bioactive, but for all the biomaterials are a case of risk. It's important to treat before. Severe metabolic disorders are also very important to treat. Calcium metabolism, steroid treatment. The medical history of our patients must be very well known before we do surgeries. Pharmaceutical calcium metabolism is important. Immunosuppressive therapy, endocrinological bone diseases, radiation, nicotine abuse. All my patients, we try to decrease the number of cigarettes until 10, no more than 10 cigarettes per day. If they have more, it's important for us to postpone the bone graft for another time. This is very, very important. And the benefits. I think that this biomaterial was designed for resorption and a new bone formation to mimic autologous bone. Superior handling with very rapid titration is very, very important. If we can add growth factors and antibiotics for various surgical indications, we will win a lot. The silicate, this more 10% of 4% of silicate gives a lot of advantages in terms of volume. For me, is very, very important. And of course, when we combine also the autologous with the bioactive, it works very, very well in terms of bone defects. And here it is now. I will stop to sharing. Okay.
Thank you so much, Dr. Duarte. It was really extensive cases, and the presentation was also very nice. I was so much involved in it, and I was just looking through all of your photographs which you have taken, from the clinical cases, and those look amazing. And the end result you have from them are really amazing. The one thing which I want to ask you is uh, as you are so much experienced with our products and also using other products and so on, where do you see Cerazor bioactive being can be shown like a very superior results in which indications you think?
It's a fantastic question, Shnia. I think in massive bone defects, it where makes all the difference. Because when we talk about small defects, the difference between the biomaterials is not so notable. But when we have a massive bone defect that we need microvascularity, we need consolidation, we will use that bone to place implants, is where we see if there is infection, if there is resorption, or in the final aspect, if there is volume to do rehabilitation. And with bioactive, my major goal that I achieved was to do rehabilitation, placing implants, and of course, even more important, placing crowns, bridges, and total structures. Because when we place these structures in occlusion, the bone will feel the strength of all the occlusion, the patient's occlusion, is when you will have the right idea about if your rehabilitation is safe or not. In summary, bioactive makes the difference in huge bone reconstructions.
Okay, thank you so much for your answer. And the next question I just want to know, because you're working with it on surgical side so much, how is it with the handling of this material at the surgical site? I just want to know how it feels and how easy or difficult it is to manipulate and so on.
It's very easy to handle. The granules, they work very well. The porosity of the granules is also an advantage, because when you see the biomaterial in contact with blood, it's so hydrophilic. It seems like it tracks the blood, and the blood works with as a channel that unites all the granules. What means that when you look to the CBCT, you will see the density of your bone graft is higher. When you mix the biomaterials with the fibrin, and it works like a sticky bone, is very easy to move from your desk to your patients. You don't lose the granules, and you don't lose biomaterials. You can compact your biomaterial. There are some small specifications that I would like to say. I don't use the same surgical instruments to handle the biomaterials, okay? I have specific instruments for the biomaterials to mix it and to handle and to transport it to the patient's mouth. I don't like mixed infections, okay? And even for the membranes, if I like to adapt a membrane, I will cut the membrane with a different scissor that I'm using in the surgery, okay? It's like I have a bone graft kit and the surgical kit, okay? I don't mix the sets, okay? It's part of the table is for the bone graft. In my hands and in my mind makes difference because I'm not mixing infections.
Yeah, and just a follow-up question because you said bioactive is hydrophilic. So when we are talking about hydrophilicity of the material, that also indicates that it's gonna after or post surgery, it's gonna show lesser rate of inflammation or infection or no inflammation or infection at all. Is that true?
It's very true. And you can see that from the soft tissues, because when you look to the soft tissue, there's no signs of inflammation or infection, and is notable since the day one. We do a very close follow-up of our patients, what means that we see the patients every 3 days after surgery, okay? Because I think the first days are very important. If your wound open is the right channel for inflammation and for infection. The treatment of the soft tissue is the guarantee of your bone graft. Is why I see all them every 3 days. And comparing with other biomaterials, we don't have so much degrees of inflammation.
Thank you so much for your answer. It really helps us to understand this product way more better, and it really gives a clear understanding. And with your clinical evidences, it really makes a difference. Thank you so much, Dr. Duarte. It was great pleasure with you.
It was the pleasure was mine. Always a pleasure to work with you.